For the last hour or two, what we're going to do is we're going to go through some of the more local resources. I'm going to introduce the AsthmaAcademy team to you, and then Dr. Rank's going to talk for a little bit, and then we'll go into our presentation. But so this is Dr. Allison Rank. She is a pediatric hospitalist. She is our medical director for inpatient pediatrics. She is also the medical director for AsthmaAcademy, which you're going to learn a little bit more about. Truly, truly passionate for both patients, families, school nurses. We are super, super lucky to have her. We appreciate her very much. So Christy and Amanda are both certified asthma educators, as am I. Christy is a respiratory therapist. She's a clinical supervisor for the inpatient side, and she also works Tuesdays and Thursdays and some other days here and there in AsthmaAcademy. Amanda Thrasher is a respiratory therapist who works as a staff therapist, inpatient, and also works in AsthmaAcademy as an educator. She is our newest AEC, that's the credentials to be a certified asthma educator, and she is the newest one to add our system. And all AnMed Health has 6 certified asthma educators on staff. That's one thing we're very proud of, 3 of which work exclusively in AsthmaAcademy. So with that being said, I'm going to let Allison take over.
Thank you guys for all coming back from lunch. Did get a little nervous about the lunch break, but hopefully everybody's not sleepy after eating. But I know thanks to Dr. Bowman and Sally, you guys have heard a lot of great information about resources that you can take back to your school. And so just kind of what our talk, an overview of what our talk is about, is what you have available here locally to help you and the kids that you take care of at school. And I think on behalf of AsthmaAcademy, we want to thank you guys. We realize the hard job that you all have as school nurses. You are on the front lines. You see all of these children every day, and you are certainly advocates for them, and we hope to partner with you in providing better care for the children of our community. We actually have a very close relationship right now with District 5. We would certainly love to strengthen the relationship with District 1. I think there's a lot of resources locally that we can help provide for you guys to help you better manage those kids with asthma. So with that, just to kind of give you guys, Mike's going to kind of talk a little bit about what AsthmaAcademy is, and we'll dig right in.
So just a few objectives. I do want to talk about AsthmaAcademy, who we are, what we do, and as Dr. Rank mentioned, some of the other resources that are available here in Anderson and the surrounding communities. We'll look at a case study, which is an 11-year-old that has some exercise intolerance. I want to talk a little bit about outcomes, and I don't want to get into a ton of numbers and things today, but I do want you guys to see some of the benefits that we're seeing through this program and this program model. And then we're going to tackle proper inhaler technique, because that's one of the things that's super, super important. And so if you guys as school nurses are empowered to really sort of reinforce and teach that correct technique, it can be super helpful for your students. A little bit about AsthmaAcademy. So we opened our doors in January of 2009. It's hard to believe it's been that long. There are 3 programs in the country that are accredited by the American Association for Respiratory Care. It's called ASME, or Asthma Self-Management Education Accreditation. Our program is one of those 3 nationwide. That's something that we're very proud of. It's a 3-year accreditation cycle, and we have just gone into our 3rd 3-year cycle. So we're accredited through 2019 as of now. We are staffed. One of the requirements is that if you're going to educate patients within this program, you must be a certified asthma educator. So currently the 3 of us that are doing most of the education are respiratory therapists. We also have had an RN who is a certified asthma educator, and her time in the emergency department has got her so busy she's not been able to come back and work with us lately, but we hope she does. And right now, we do this 2 days a week. So as you start to hear the outcomes and some of the different things we do, know that we have clinic days 2 days a week. We function outside of our clinic hours. We'll do some by appointment only times, or we do get out to schools on some of our days off and things like that. Now, when I say days off, I'm also the manager for inpatient respiratory care. I manage the pulmonary diagnostics department in addition to being site coordinator for AsthmaAcademy. So my days off from the clinic aren't actually days off, and the same holds true for every one of us who are pulling this program together. So it's interesting that we've built this program and been super successful, but it's just been through this kind of reallocation of how we do things. It wasn't that we said, hey, let's hire 4 more people and figure out how to do this. So it can be done through a reallocation of resources and having passionate people like Christy and Amanda and Dr. Rank who are willing to work really hard. So the process is that somewhere along the way, a child with uncontrolled asthma or even questionable asthma could be referred to us. We take referrals from primary care physicians. We take direct referrals from school nurses. That's an option. It's not our preferred option. We'd rather that school nurses and primary care physicians, be in communication with one another, and then the primary care doctor make the referral to us. But if that can't happen, you as a school nurse can absolutely refer a patient to us.
They have to live in Anderson County, I'm assuming.
Nah, it doesn't matter where they live.
Really?
Nah, it doesn't. We'll see anybody. It's fine. We see right now we've seen children from Oconee, Pickens, Hartwell, Elberton. Yeah, no, it doesn't matter to us. If they have poorly controlled asthma and we can help, bring them on. That's fine. So we do a lot of lung function testing. We do a lot of individualized asthma education. We develop asthma action plans. And what happens is that the patient, let me even back up just a little bit. So throughout, my 25 to 30 years as a respiratory therapist, asthma clinics are not new. They've been around forever. And so what I've kind of seen over time is that a physician practice may have an asthma clinic, and kids get treated in that clinic, and it helps those children within that clinic. But it doesn't really do anything for the rest of the kids in the community, and not every physician practice has an asthma clinic. So as we began to design this, we wanted to build it in such a way that it didn't matter really whether I wanted to help kids whether they walk through our doors or not. So it's like, how can we make a program where, number one, we're helping increase the level of guideline-based care. Dr. Bowman mentioned the guidelines before, the EPR3 guidelines. That's certainly what we follow. And we wanted to benefit kids who couldn't necessarily come see us. So the way we do this is we do the education, we do the diagnostics, and then we see ourselves really as a tool for primary care physicians. So we channel back to primary care all of that information. We sort of fill a niche between subspecialists like Dr. Bowman and primary care physicians, because you don't have to be an ologist to teach somebody how to use an inhaler the right way. It's really, that can be done, at least theoretically, in the primary care setting. But primary care doctors have about 10 minutes to take care of everything. And so there's somebody that's got to sort of jump in between and handle some of those things. And so that's what we do. We do the education, the diagnostics, get that information back to primary care. Sometimes that recommendation is, your patient really needs to go see a Dr. Bowman or an allergist or whatever the case may be. So that's sort of the way we built this program. This is just a graphic that we've used several times, but it sort of shows our mindset in that we're this program. Everything we do is surrounded by guidelines, but it's really a series of relationships that make the program successful. And those relationships include a lot of people. And so primary care doctors, nurses, inpatient nurses, school nurses, community health workers. If you just think about the child with asthma, everyone who interacts with that child's life could potentially impact how that child manages their asthma. And that could be, grandma, granddad, aunts, uncles. So it's all these relationships. We want to help sort of close gaps there. The education that we typically talks about medication adherence, inhaler technique, environmental control, comorbid conditions, early symptom recognition, a standardized asthma action plan, and we'll talk more about these individual things as the talk goes on. The top two, medication adherence and inhaler technique, those may be the two most important things that we talk about, because if you're not taking a med that's been prescribed or you're not taking it correctly, then it doesn't matter if you go to your physician and say, ooh, you're not doing too good, let's crank up the dose, or let's add another medicine. It's not, adding another medicine that you're not going to take or that you're not going to take correctly isn't going to help you get any better. Inhaler technique, we'll talk a lot more about this later, but as Dr. Bowman mentioned earlier, there's two spacers, one with a mask, one without. Generally, as kids get to be about 5 years old, they should be transitioning away from the mask and towards the mouthpiece. So if you have students who are older than 5 and they have the yellow spacer or they have one with a mask on it, I would at least consider talking to somebody about getting them switched over to the other kind. They get a lot more medicine with the mouthpiece. Some of the tests that we do spirometry. There's a test that's not a new technology, but it's relatively new in our area. It's called impulse oscillometry. And this is really neat because you can just, you can get lung function measurements with just normal tidal breathing. So children who are not old enough to do everything it takes to do spirometry, we can get, what's most helpful for us is we can see if there's resistance to airflow and we can see if it's reversible. So that helps in those. I think Christy wins the prize so far because she's done a 2-year-old. So she's gotten good measurements with a 2-year-old. But for those 3 and 4-year-olds where really all you have to go by is mom or grandma says the medicine doesn't help. And that's so tough. And then we also do exercise provocation studies, which we have a case that we'll talk about there. This is just, I promise you we're not going to go through all this stuff, but this is some of the measurements we see. But the really important thing I want you to see on the very bottom, I don't know if you can read it back, but it just shows us this child has mild obstruction, significantly reversible with bronchodilators. And this is a 3-year-old. So when you have the 3-year-old and you can prove or disprove reversibility, that certainly helps you know whether you're more likely to be wandering down an asthma path or perhaps not an asthma path whatsoever. And this is simply another version. This talk has also been given to, Dr. Rank gave this to our local residents here, our resident physicians here, and so went into a lot of in-depth discussion on these. I promise you we're not going to do that. Dr. Rank, you want to do the case study?
So of course I love cases, but I think this case actually demonstrates a lot about what we do in AsthmaAcademy and how sometimes what's presented that looks like one thing may not always be that, so not all that wheezes is asthma. And so this was an 11-year-old that had been referred to us for this history of exercise intolerance. We were getting this history from family members, the patient, from the primary care doc. This kid can't exercise. We think they have asthma. The patient was currently, at the time we initially saw them, was on Symbicort, which is a combined inhaled corticosteroid with a long-acting beta agonist. They were on Flonase and Zyrtec for allergies. The family reported that the kid wasn't using Flonase, that he was using a mask spacer, and so this is an 11-year-old. They were reporting frequent allergy symptoms and had recently been started on Symbicort. So the parents were reporting that maybe had been doing a little bit better since the Symbicort was added. So we initially saw this patient, kind of did an in-depth symptom control questionnaire and found out this kid was symptomatic pretty much almost every day, almost every night, was using albuterol almost daily, and really wasn't exercising or participating in any physical activity because of this perceived inability to. So the initial spirometry that we did showed that this patient had moderate obstruction and that there was significant small airway disease, and so which is very common in kids that have asthma. It's not really the large airways that are affected, it's really deep into the lungs, the very tiny small airways, which is why one of the reasons why we recommend the spacer, right? It helps to filter out the big particles of medicine so that the really small ones can get deep into the lungs. And then we were also able to demonstrate that this patient responded to albuterol. So we gave the albuterol, the airways opened up. So at that time, we did a really intensive asthma education with the family, got rid of the spacer and the mask, taught the kid how to use the spacer with the mouthpiece, really worked on kind of enforcing, compliance to medication and taking the controllers, even the allergy meds every day. We had kind of in our mind thought of a lot of contingency plans. So if we were doing all of these things, what else were we going to do? But we didn't want to make a ton of changes with our first encounter with the patient. We were considering kind of stepping up therapy. We were considering adding additional medications. But we wanted to see this kid back in about 8 weeks to see just with good compliance and technique, could we improve? So they actually missed their 8-week follow-up and followed up at 12 weeks. And at that time, the family reported that we were doing a little bit better with controllers, but still not really using the spacer at all. He was now getting Symbicort, but just not using it correctly. So the spirometry at that time showed a little bit of improvement in the airway obstruction, but really essentially unchanged. Still pretty significant obstruction in the small airways. We still, at that time, the patient was not exercising because of the limits, and we were not able to actually do an exercise provocation test on the patient because the obstruction was so bad to begin with. So at that time, we again spent a huge amount of time kind of reinforcing how to use the spacer, why the spacer was necessary every time they were using the inhaler. We talked a lot about inhaler technique and trigger avoidance, and then kind of set some goals with the family and the patient of what our goals were. We wanted this child to have normal lung function, or as near normal as possible. And at that time, again, we decided not to make any change in medication, which I think sometimes it's always been our approach. Instead of throwing a lot of medicines, we really want to make sure that we always go back to the basics. Are you getting the medicine? How often are we missing? What's our technique like? So I think very easily, if we had just taken a step back and not really gone into in-depth to realize where these pieces were breaking down, somebody may have just increased medicines or added additional medicines. And so then we again encouraged this kid to get back with the primary care doc. We were making appointments for the family to follow up. So a 1-month follow-up was made, and at that time we were trying to decide, were we going to change the controller medication? Does this kid need to go to a pulmonologist? We need to think about allergy testing. So we actually saw this patient back a little over a month later. The family actually reported that the patient was consistently using Symbicort now with a spacer. They were still intermittently using Flonase and maybe not as compliant still with allergy medication, but still having some allergy issues. But the patient was reporting some improved exercise tolerance, but still reporting that they were getting very winded quickly. So at this time, interestingly, the spirometry was actually normal. So just from 1 month of actually using appropriately with a spacer, we had normal lung function. And so at this time, we were able to exercise him. So we put him on the treadmill and we exercised him. He went really hard, had a really high heart rate for 6 minutes. He complained of shortness of breath and chest pain during the exercise test. And then we did spirometry for different periods of time after the intense exercise. And it actually was negative for exercise-induced bronchospasm. I think Dr. Bowman touched on that a little bit earlier. Mike also kind of mentioned, I think in the discussion, that a lot of these kids report that they don't have exercise tolerance. So when you actually do an exercise provocation test, in the vast majority, there really isn't exercise-induced asthma. However, there are a subset of kids that do have exercise as a trigger. And so really what this boiled down to is most likely it was poor conditioning. So once we got his asthma under control, we really want to encourage him to do normal physical activity, but we can prove that he doesn't have exercise asthma. So that really shouldn't be a limitation, but his perception is probably more due to poor conditioning, which is a lot of the kids that we see. And so at that time, we recommended that he continue his current meds. We really tried to get compliance with the allergy medications, and then really encouraged him to start working up with an exercise program to improve his conditioning, and then follow up with his primary care doc. And so this is just an example of one of the exercise tests that we do. And so what we're looking for is the FEV1, which is one of the measurements that we do. If it drops below this line, then that would be a positive test. And so he had a small decrease, but it wasn't significant enough to call it exercise-induced asthma. And so it was nice to be able to rule that out, right? And so a lot of the kids that we get, I'd venture to say probably 75% of them are negative tests, but there is about 25% that come back positive. So the big take-home messages for this are spacers matter, which is why I think if we can teach you guys how to use it, you can help to teach your patients, but you'd be surprised the number of families and patients that have no idea how to use it. That technique is super important. So not just having the spacer, but do they know how to use it the right way? And that not all that exercise intolerance is exercise asthma, so something to remember. And that we are a guideline-based clinic, so we really encourage stepping down therapy once we've had 3 months of good control. And so stepping up or stepping down kind of in 3-month intervals based on the guidelines. So one of the newer modalities that we've kind of added is we know that comorbid conditions affect asthma control. And so Dr. Bowman kind of hit a little bit on the fact that not all kids that have allergies have asthma, but they are at increased risk. Especially in this area that we live in. You guys know how terrible the allergies are here. And so what we decided to do is we knew that there was this subset of patients within asthmania that we were seeing that were frequent flyers. They're high utilizers. They're in the ER a lot. They're probably in your offices a lot. They're in our urgent care. They're being admitted to the hospital. And so what we really wanted to do was go after these high-risk kids that were poorly controlled and look at whether allergy disease was playing a part in their poor asthma control. And so one of the tests that we're now offering is immunocap testing, which is a blood test that you can do to look for allergies. And it's actually specific for the areas that you live in. And so it's testing for our most common environmental allergens that are here. It's things like pollens from trees and weeds and grasses, pet dander, cockroaches, mouse urine. There's a whole panel of things that are on there that can really give us a great wealth of information to help us get information back to the family about limiting exposure, things that could be triggering asthma. And so what we do is we do targeted counseling then for risk and allergen avoidance for these families. We've actually partnered with Pam, and I was going to get you so Project Breathe Easy, which I'm about to talk to in a minute. So we actually have a partnership within Anderson that we're able to use where we can go out to the home and actually do home assessments. So once we know what the kid is allergic to, then we can actually have a community health worker go to the house and help the family decide, these are things that you might want to avoid. Here's mold in the house. This is how we would recommend that you talk to your landlord or get rid of it to help improve asthma control. This is just an example of what one of the allergy tests look like. Essentially, it comes back, and the things that are really elevated are the most positives. Like this kid had really significant allergies to grass and trees, and also had some mold allergies which are at the bottom. So the highest levels are the things that they're most allergic to. So again, if we know what they are, then we can help them avoid it. So Project Breathe Easy, how many of you guys have heard about Project Breathe Easy? Is anybody aware of Project Breathe Easy? So it's a DHEC resource through South Carolina, and so if your asthma patients aren't aware of it, please help encourage them to get involved. But essentially it's an emotional support group, so it's parents that are helping other parents of kids with asthma, but they also help to provide pillow encasements and mattress encasements for the home to help limit those exposures to dust mites. And so really, they've been an invaluable resource here in our community, and I would encourage you guys to try to get your patients involved in that as well. And what they've shown, they've got some pretty good data that shows that families that are involved in Project Breathe Easy actually have less absences from school. The parents are missing work less because their kids are better controlled with their asthma.
This is just for Anderson and Greenville County?
I believe statewide. Yep. So this is an example of an action plan. I just wanted to ask, so in your schools, how many of you guys have action plans for all of your asthmatics? Ooh, wow, that's impressive. That's more than I thought.
Like that?
Doesn't have to look like that, but has a stoplight, green, yellow, red. Does that kind of look familiar? So how many of you guys would say about 50% of your kids have action plans? Okay. And so are there people that are in schools that have no action plans for kids that have asthma, that are known asthmatics? Is anybody operating under that? Okay, good. Well, sure. And so part of what we do in AsthmaAcademy is making multiple copies of this so that we're trying to get a copy to you guys. But sometimes if we also know what school they're in, we get permission from the parents, and we'll actually send you guys directly a copy of the action plan. I think it's a great tool for you guys to have in figuring out how we can help you get that. So if there's a role that AsthmaAcademy can have in that, we would certainly try to help you with that. So several years ago, we decided as an institution within ANMED to standardize our action plan so that every doctor's office, every point of contact within our healthcare system, the patient would get the same action plan. So there was a consistent message being sent to the family. So we've got two different action plans here at ANMED. So for kids that are 5 and older, and then that are less than 5, and they're all standardized. So everybody gets the same doses, has the same yellow and red zone, so it makes it really easy. But you guys know the purpose of the action plan, so that the green is when they're doing well, so all of their controller medications go there. We like to put all of their allergy medicines there as well, so if they have allergies as well, we want to remind them it's still part of good asthma control is controlling their allergies. And then you guys are familiar, you're probably seeing these kids either in the yellow or the red zones. So really teaching the families how to recognize early symptoms of poor control, and then going ahead and treating. So the 4 to 6 puffs when they're in the yellow zone, kind of repeating again. And then if that doesn't work, going on to the red zone. where we do really high doses, so 6 to 8 puffs, and so it should be kind of a standardized approach. And then the one thing I will point out is for those kids that do have proven exercise asthma, then that's really the only place that we use the 2 puffs of albuterol. I think traditionally we always hear about 2 puffs, but really 2 puffs isn't going to do anything when there's actually obstruction, except for the caveat of preventing exercise-induced asthma. And so sometimes your patients you will see will have the checkbox for the exercise. Have y'all seen this action plan at all with any of your kids? Good. And so the one thing that I would like to say about the exercise asthma is that this is the one time where the pre-medication with albuterol is helpful. And so I think Dr. Bowman kind of mentioned kind of doing your own little experiment to see like pre-medicating these kids for a week and seeing if that changes their symptoms, or talking to the family, having their primary care doctor refer them to us. We can do the exercise testing to prove whether it is or it isn't. But I think the big thing about pre-medication for exercise, if it is a trigger, is that once they start exercising and they get the bronchoconstriction, it's a lot harder to bail them out than it is to pre-medicate before. And so this is the one time where the kid may come to you and say that they need their inhaler, and they probably won't have any symptoms at that time before exercise. Most likely they're not going to be wheezing, they're going to have good lung function. But if you give the albuterol 20 to 30 minutes before they exercise, then you can prevent the bronchoconstriction from happening. And I think we also are strong proponents of good physical activity, right? I mean, our goal in AsthmaAcademy is that kids with asthma should be able to do everything that every other kid does, and that asthma should not limit their activity, should not limit their participation in sports, shouldn't limit their ability to go outside. It just means that we as doctors aren't doing our job if we haven't found the right medications and haven't done the education to teach them how to control their disease. And so if you look at kind of what we've seen in looking at the kids that have come through AsthmaAcademy, so we have decreased our hospital admissions for pediatric asthma patients by about 50%. We have had a 50% reduction in the pediatric asthma patient days. So Dr. Bowman mentioned just how costly pediatric asthma is. It is our #1 chronic condition. It's billions of dollars nationwide that we spend on pediatric asthma, and so we've been able to make an impact here within our little system. And we've had a 12% reduction in our length of stay. So when we first started managing asthma here, around 2008, 2009, we developed a respiratory therapy-driven bronchodilator weaning protocol. So we really empower our respiratory therapists to be able to wean these patients very quickly. So that we've decreased significantly the amount of time that they're in the hospital. And then this just shows you kind of an overview of the kids that we're managing here with asthma. And you guys can see this was before AsthmaAcademy started. We started up around 2008, 2009. It was also around the time that we started our pediatric hospitalist program, so things were kind of going hand in hand. And then as you can see that we've steadily dropped in the number of inpatient admissions that we've had. And we'd like to think that maybe we've had a little bit to do with that. And then if you look at our length of stays, again, we're kind of looking at there's 2 different things here, the blue being our pediatric asthma length of stay days, and then the red being those kids that actually come in status asthmaticus, so having very severe asthma exacerbations that are requiring a lot more aggressive therapy and potentially going to the pediatric ICU if they're not improving. So we've actually are taking care of less kids in the hospital, but they're actually sicker. And so they're coming in a little bit more severely flared than they were before. If you look at our number of readmissions, this is the thing that we're most proud of. So we actually have not had a pediatric asthma readmission really since 2013. And if you look at 2013, there were 5 readmissions, and none of them were for asthma. So these 4 kids came back within 30 days of hospital discharge, but they weren't readmitted for asthma. They were admitted for other things like skin infections, or I think one was a vomiting diarrhea. So really, I don't think that we've had a direct pediatric asthma readmission since 2011. So something that we're pretty proud of. And part of that is that every kid that gets admitted to the hospital is set up with AsthmaAcademy at discharge. So the same educators that they're meeting in the hospital are also going to see these families on the outpatient basis, and we're consistently all sending the same message. We're constantly going over spacer and action plan, and just making sure that we give the family and the patient the tools they need to well control their disease. And then if you look at the number of visits that we've had in AsthmaAcademy, so kind of steadily going up, the word's gotten out, and it was probably about 2 or 3 years ago that the pediatric community kind of made the decision to really give you guys the ability to make referrals directly to us. I think primary care doctors in this area are fully aware that they can't always get to everything that's on their desk, and that we all recognize that you guys are in a much better position to really recognize those kids that are either undiagnosed or that are poorly controlled. And so we'll show you guys, if you're not able to get the primary care doctor to make that referral, we want to empower you to make that referral to get the kids the help that they need. And then the other thing, which I think as we move towards a value-based healthcare system and thinking about what this looks like for the system. So what we did is we looked at kids within our system, their charges within AnMed, so in the emergency room, in our urgent care, and the hospital. We looked at how much money was the average charge for all of those kids before they came to AsthmaAcademy. They went through AsthmaAcademy, they got their testing, and then we followed them for a year later and looked at the difference. So this is kind of the most exciting thing, is we kind of cut the cost down in half. And so this is the average per patient. So they were spending about $5,500 before AsthmaAcademy, and then after AsthmaAcademy, it was down to about $2,100. And that included actually the testing that we were doing within AsthmaAcademy. So pretty good value for your money. And then if we looked at the whole system as a whole and added up all of those kids, so we were spending about $285,000, and then for the year after they came to AsthmaAcademy, we only spent $113,000, and that would have included if they were admitted to the hospital or going to the emergency room. And so how can you refer to AsthmaAcademy? We actually have some of the paper referral forms in the back. This is our telephone number, and we have our cards in the back as well. So feel free to call any of us if you have questions, if there's something that we can help you do with your patients. We're here for you. And then we're going to show you our website because it's also got some other information. So things that we're doing, which we have already been doing, I think schools is certainly the area that we want to continue to build on. We would love to come out and do an education session for you and your teachers. We do parent education sessions. We've done sessions with the students. We've actually worked with a couple of school nurses within District 5 who have these high-risk kids that are frequent flyers, and then we've actually come out to the school and done asthma education for them at the school. And then we go back 6 weeks later and see, can they teach us how to do an inhaler? Or can they show us how to use their spacer? And so there's things that we're creative. If you guys have ideas about ways we can help you, we would love to partner. Telemedicine, I think, is the next kind of realm, certainly as we're trying to give access to patients that may not physically be able to come to AsthmaAcademy. So we're certainly exploring how we can do that. We actually have a couple of iPads that we've been working on doing some telemedicine. And then we've also really been working with our local physician offices to get asthma champions in each of the offices. We realize they don't have an hour and a half to do the teaching and the education that we do in AsthmaAcademy, but if we can train someone within each office as the asthma champion, that can really take that on. And so we've been working with some of the pediatric practices to do that. And then, like Dr. Bowman said, the fight continues to really try to get our payers, our insurance payers and Medicaid to value the preventative care. And so really trying to get them to reimburse for asthma education, which is a fight that we continue to take charge of. And so Dr. Bowman mentioned the guideline-based therapy that we do. Do you guys have any questions about that?